Okay, great. Looks like we have a lot of attendees in. So hello, thank you everyone for joining. We're going to get the program started with some brief introductions. I'm Amar Fahmi, and I have the privilege of moderating this webinar. I'm a first-year student at the University of Michigan, and I'm involved with the UNICEF Unite Detroit team and the National Arab American Medical Association, NAAMA NextGen at the University of Michigan. Before we get started, we're just going to go through a few logistical things. We go to the next slide. So just briefly, some webinar rules. We're trying to have a safe and inclusive environment for everyone involved. So there's a zero tolerance for anything vulgar or discriminatory in the chat. Anything of that nature will be flagged. Obviously, it's not advised to share private information in the chat. And the share features will be limited, and any questions should be directed through the Q&A functionality. What is shared in the chat by non-UNICEF USA members or by non-NAAMA members does not reflect the opinions or beliefs of either respective organization. Thank you so much for listening to that. So we have a great lineup of panelists all on the front line of this pandemic who are in the emergency room, intensive care, and internal medicine. They'll tell us a bit about themselves, their experiences with COVID-19. We will go into the pre-submitted questions that the audience provided when you registered. We'll open up the floor for some additional questions. And finally, we'll have some closing remarks. So without further ado, I would like to introduce our amazing NAAMA physicians. First is Dr. Safwan Badr, who is a professor and chair of internal medicine at Wayne State University School of Medicine. He is also the chief of critical care and pulmonary medicine. Next is Dr. Osama Msallam, who is an emergency room physician and the vice president and medical director of International Initiative at Henry Ford Health System. Finally is Dr. Fuad Batah, who is a senior physician of internal medicine and the founder of Premier Internists. Dr. Batah actually got infected and then recovered from COVID-19, and I'm sure we'll hear more from him about that. So if we could have a few introductory remarks by our panelists in the orders of Dr. Badr, Dr. Msallam, and Dr. Batah, and then we'll start addressing the pre-submitted questions. So Dr. Badr, if you could please start us off.
Okay, good afternoon, everyone. Actually, the weather is crummy, so being indoor is okay right now, feeling quarantined. Well, as mentioned, I'm at Wayne State University and the Detroit Medical Center and the John D. Dingle VA. So this particular pandemic has had the same effect that it has on everyone else, which is worried about our own health and the health of our families. I have not seen my mom, who lives a mile away from me, for about a month. However, she's now very good at FaceTiming. So there are changes. I'm also involved in the whole response of the DMC and the VA. And one of the big concerns we have, whether we have enough staffing, enough teams, enough physicians, enough nurses, respiratory therapists. There were times when there was concerns about adequate numbers of ventilators, and fortunately that is no longer an issue. And there's also, I actually did round in the intensive care unit for 2 weeks during the past month, and I got to see firsthand the challenges of treating patients with COVID-19 who require ICU care. Everything we learned about physiology at any point is out the window. It's a very complicated physiology when patients get to that level. But I also saw the great teamwork, camaraderie, and collaboration across specialties, since all of us are scratching our head and trying to find solutions, across disciplines, respiratory therapists, nurses. And you realize that truly critical care is the ultimate interprofessional discipline where physicians, nurses, therapists, and clinical pharmacists all work together. And we had to develop protocols on the fly to address issues that we never thought we had. So it's been challenging on multiple fronts, but I think we'll all be stronger at the end, and this too shall pass. That's it.
Thank you, Dr. Badr. So hello, everybody. Good afternoon. My name, as Omar told you, is Osama Musallam. I'm an emergency physician at Henry Ford Health System, and I am actually an actively practicing clinician at the Henry Ford Hospital Emergency Department in Detroit. I do many other things for the system, including the international piece that you heard about. But today I'm here to address it from the perspective of the emergency physician. I have been active clinically. I've worked, over the past month, I would say, much to the chagrin of my family, almost 12 shifts, 120 hours in the emergency department, from what we call a screening tent to the critical care area of the emergency department, as well as the main emergency department. In fact, I'm home. I just came home from a 10-hour shift in the emergency department today. So fresh off exactly what COVID looks like and what's presenting and how to treat it, at least from the initial perspective, until we hand off to our colleagues in the critical care realm or on the inpatient floors, as Dr. Batah will tell you soon. So it's a privilege. Thank you for having me, and I look forward to answering your questions.
Hello, everyone. My name is Fuad Batah. I'm an internal medicine physician, and I usually round at the hospital. I have privileges at Beaumont Hospital in Royal Oak and Providence Hospital, but I make rounds at Beaumont, and also I have outpatient practice. So when the COVID-19 pandemic started in Michigan, we started seeing some patients. Beaumont approached the physicians who are willing to volunteer to round on COVID units, and we decided to do that. So the first week I rounded on COVID floor. So I had one of the teams. So we were seeing about 16 to 20 patients a day on COVID unit. So we got to see really these patients on a regular medical floor. It wasn't progressive or intensive care unit. It was a medical floor. So these patients were a little more stable than the patients that Dr. Badr got to see. Also, at the same time, I was seeing still some patients in the office, but also we start doing the video and telehealth visits with the patients, start seeing a lot of patients who either tested positive or had enough symptoms, but really at that time, probably up till now, we're not testing everyone. So we clinically had to make a decision on who has it and what to do for these patients. Well, I had some symptoms at the end of the second week, rounding on the floor, and I tested positive. So I had to quarantine myself and my wife. Actually, we tested positive. So I stayed at home. Luckily, the symptoms were mild, and we can get to talk about that as a patient in a little bit. But during that time, I was doing a lot of video visits with my patients. And so we got to see a lot of COVID patients from every perspective, really, in the hospital, outpatient, and also being a patient myself. So I'll be happy also to answer more of the questions that will be coming up.
Great, thank you to all three of you for joining us today and sharing a little bit about yourselves. So as a reminder to the audience, I'm not sure if I mentioned this feature before, you can actually participate in our interactive poll, which should be at the bottom of your screen. Feel free to use the Q&A for fielding questions later. And so now we're going to go into the pre-selected questions that you guys submitted when we first opened up registration. So this one actually pertains to a lot of our audience members who are college students. So I'm a college student. The audience is mostly undergrad. So the first question, if one of us was to contract COVID-19, how would the symptoms manifest for us? And I'm going to direct that to Dr. Batah.
So probably most of you, have been looking at the news and reading a lot of articles. The symptoms vary a lot. So for outpatient presentation, when the patient first gets sick with COVID-19, what I've seen mostly is low-grade temperature, sometimes not low-grade, high temperature, where most of these high-temperature patients will end up in the emergency room. But patients who get to stay home or early on in the disease will have low-grade temperature. Common symptoms are cough, mild shortness of breath. What I've seen a lot of, it's a loss of taste and smell. That was very common symptoms I've seen. Of course, fatigue, muscle ache, and that varies a lot. Some people have very minimal muscle ache, but some people have severe muscle ache where the patients cannot move much. Of course, there are some GI symptoms from nausea. Diarrhea was a common symptoms of what we've seen. When the patients get really more respiratory symptoms, especially shortness of breath, when they become hypoxic, the oxygen level goes down, have some chest pain, those are the patients that end up usually going to the emergency room, get tested, and possibly admitted.
Thank you, Dr. Batah. And so as a continuation of that is a two-part question. So Dr. Msallam, coming to the ER, what is the most common presentation that you see? And the second part, Dr. Badr, could you break down the symptoms by severity? So Dr. Msallam, please.
Yeah, sure. So very much similar to what Dr. Batah said. We see patients, initially when we were seeing it, we see lots of patients presenting with very similar symptoms complexes, right? The majority of what I see in the emergency department and what worries me, frankly, are the things such as shortness of breath, something we call conversational dyspnea. So basically inability to even just have a conversation without becoming short of breath or without coughing. In fact, I saw 3 of those patients today. Chest pain mostly associated with cough or shortness of breath, and sometimes other chest pain etiologies that are related to heart-related symptoms that we've seen with COVID. Lots of GI, Dr. Batah is actually right, lots of GI, lots of diarrhea, lots of nausea. We do ask about loss of the sensation of taste and smell, and that's something that we're seeing fairly commonly. And then actually what we're also seeing, which is significant, is lots of people with fear, right? Anxiety related to this, whether they've been exposed to somebody or they've had it, or they've been taking care of somebody who has it. So we're seeing lots of mental health related symptoms related to the fear of it, or because they might have it or have been diagnosed with it. So that's, and then obviously that progresses to severe shortness of breath, where people are breathing, twice as much as what a normal would be, hypoxemia, so the inability to actually have oxygen in the bloodstream, which then leads to some critical things where we're actually having to put them in the ICU or put them on ventilators, and that is a whole host of things. So that is the complex that we see mostly. And then what happens for us is the people who are hypoxic, who have a low oxygen level, who are severely symptomatic, who are quite dyspneic or can't breathe, who have respiratory rates that are really high, or people who can't even walk or ambulate without requiring oxygen assistance. Bad pneumonias on both sides of the chest, of the lungs. Those are the patients that we then are admitting.
Okay, so usually we get asked to see a patient either in the emergency department or on the floor who is getting worse. And the symptom that brings the intensive care team is, for the most part, it's related to the fact that they really have a pneumonia. It's a viral pneumonia. And they are very short of breath, they're breathing very rapidly, and they are unable to maintain their oxygen level now. The normal oxygen level is usually, we are all breathing 21%, which is what in room air. And these patients will start requiring higher and higher levels of oxygen to maintain a reasonable level of oxygen, what we call oxygen saturation. When we get to the point when it's actually refractory, you get to 100% and you're still not making significant difference. This is where the ICU get consulted. Sometimes, given the limitations of, there was a time a couple of weeks ago where ICU beds were not available, so we tried to do everything to temporize. For example, one of them is lying on their stomach. We call it the proning position. That will help with their oxygenation. Eventually, when all of this fails, they need to be in the intensive care unit to use mechanical ventilator to support their ventilation. Now, the other part of a pneumonia is it manifests as a systemic infection. So we could have all other organ involvement. The biggest one is that they will actually drop their blood pressure. And once they're unable to maintain the cardiac output and the blood pressure and sustain their blood pressure, sepsis, that's another reason. And as they're in the intensive care unit, we're discovering all kind of unusual things that we're starting to see. Cardiac injury, clots in the lung, which I think our ED docs are the first people who have alerted us to massive clotting that's happening, renal failure, and this is what we refer to as multiple organ failure. And usually in some patients, this is very challenging. Those who are older, who have kidney disease to begin with, hypertension, diabetes, tend to have a worse outcome. It's been very, very challenging for all of the people who are involved in intensive care management for COVID-19 patients.
Thank you, Dr. Badr. And as a follow-up question, and all of you touched upon this already, but how do you manage each of these patients and their respective symptoms? So to Dr. Batah, that's outside of the hospital, to Dr. Musallam arriving in the ER, and to Dr. Badr in the ICU itself. So Dr. Batah, if you could please start us off.
Sure. Well, I'm going to talk about two aspects, the outpatient, but also the regular medical floor, because the management is totally different than intensive care unit. I'll try to be as brief at the same time, give enough information if I can. So for the outpatient management, again, a lot of times we diagnose these patients clinically by exposure and symptoms. And a lot of them we got to test, so we know they're positive. A lot of the treatment mainly as outpatient is supportive care. So we advise these patients to quarantine. That's the main issue, so don't spread the disease even to their families, but also to other people. Plenty of fluid, rest as much as possible. And there were different articles about certain supplements, mainly vitamin C and zinc and vitamin D. So we recommended to all our patients to be on a high dose of vitamin C, zinc, and vitamin D. Early on, we didn't treat with anything else. If they get sicker, then they go to the emergency room and see if they need to be admitted or not, and to get a chest x-ray and to get a test for sure. But later on, there were a lot of articles about even treating these patients early on with the combination of azithromycin and hydroxychloroquine, which is Plaquenil. So we started using some of these medications early on because a lot of studies showed that the benefit of these medications might be early on than later on when they get to the intensive care unit. So, but also to find these medications, sometimes it was a challenge. Even to find vitamins, it was a challenge. That's for the outpatient portion. For the patients who I took care of on a medical floor, so usually these patients are a little sicker, but not sick enough to be intensive care unit. A lot of these patients had pneumonias. Some of them did not on the chest x-ray, but a lot of them had very similar appearing chest x-ray, and probably Dr. Badr will mention that. So they had bilateral infiltrates, usually on the periphery, usually in the bases of the lungs. A lot of them are hypoxic. We took on our medical floor up to 6 liters, but really we end up having patients on 15 liters sometimes, or high flow oxygen, because the progressive units and intensive care areas were full. So we had to take care of those patients. A lot of these patients we treated a little more aggressively. So we put them on azithromycin and Plaquenil. A lot of times we added some antibiotics to treat as bacterial pneumonia, especially when we do blood tests and we see procalcitonin level is elevated. A lot of these patients, we did inflammatory titers on them, like CRP, ferritin level. And recently, last couple of weeks at least, because I'm back seeing the patients again since I recovered, a lot of patients were doing D-dimers on them. So the people who have higher D-dimers, we're treating those patients prophylactically with full dose anticoagulation, usually Lovenox, 1 milligram per kilogram, twice a day, because there are a lot of studies show micro embolisms or actually PEs. I just had a patient who was discharged from the hospital, got sicker, and then readmitted with bilateral PEs. So I think I'm going to stop at that point so the other doctors will mention about their experience.
Yeah, so from our perspective, we've done both. Obviously, I can tell you about 70%. So our experience at Henry Ford Hospital in Detroit, and some of our other satellite hospitals and emergency departments, 70% of the patients that we see, we're sending home. And with that, we are given advice on home treatment. And it's, as Dr. Batah said, it's really symptomatic, meaning anything to help you feel better, if it includes cough remedies, right? Lots of fluids, rest, Tylenol. We've actually, and I'll let Dr. Badr speak to that a little bit, but Tylenol, avoiding Motrin, even though the studies suggest that maybe it wasn't as bad as, initial thought, but really, so keeping their fevers away, drinking and hydrating. The most important thing that we wanted them to do, we were actually sending people home with what we called COVID kits. So a pulse oximeter for those people who are just on the fence, and we were saying, you know what, you look like you're okay, you're young enough, you'll probably do fine. But if you get worse, right? So how do they get worse? Basically before it was symptoms, but for some, we would actually send them home with a pulse oximeter, a thermometer if we wanted them to check their temperatures, we wanted them to check their oxygen saturation, and then symptomatic treatment. We initially started out with some of these folks prescribing antibiotics, not hydroxychloroquine from the emergency department for those people we were sending home, but even more recently, we've been actually staying away from antibiotics, because if we think it's COVID and it looks like COVID, and especially if their test is positive, but they don't need to be hospitalized, we're not treating for a concomitant or concurrent bacterial pneumonia. If they're really sick, for the ones, so that's 70–75% of the patients that we saw. For the really sick ones who were sick, right, they were assessed appropriately, either at home by themselves, or they called somebody who said, you sound like you're much worse, go and get checked out. Those people who had bilateral pneumonias on both sides of their lungs, those patients were putting on oxygen, or were actually proving that they needed oxygen. So we'd make them walk around the emergency department with an oximeter on to prove that they actually are, or they couldn't speak or couldn't breathe or needed oxygen. And those patients who we decided would be admitted to get a panel of blood tests, including the D-dimer that Dr. Fatah referred to, looking for those microemboli. And we did all of those other inflammatory markers, looking for severity of disease. And some of these people, depending on where they came from, whether they're dialysis patients or not, nursing home patients or not, would be started on antibiotics for bacterial pneumonia. And then we would actually start also things such as the Plaquenil, the hydroxychloroquine, right? Plus or minus, if they needed significant amount of oxygen, we put them on steroids, and amongst other things. But anything more than that or more complicated than that, we would defer to our inpatient colleagues like Dr. Fatah, Dr. Badr, and our infectious disease specialists.
All right. Well, what we deal with at the intensive care unit is pretty much a continuation of what we've heard about the floor and the ED. There are a few key relevant points. We are flying by the seat of our pants treating this condition. We do not have large clinical trials of the kind that we would consider level 1 evidence. So everyone around the country is scrambling, and they're putting together protocols. For example, the hydroxychloroquine and azithromycin, that's a protocol that was started from one place and everybody copied it. Then said, well, you know what, there is a cytokine storm, it's an inflammatory process. And some people said something about IL-6 blockers, and we have patients on them. Then said, well, this is a viral infection, let's try the remdesivir, and some people tried that, and that's another one of these. Then actually the anticoagulation, the thinning of the blood, this is actually an interesting one. It was the nephrologist who drew attention to it, saying, guys, we're trying to put these, to dialyze these patients, and the lines are clotting. And then everybody came up with a number. That's D-dimer is one of the measures that we will look at. And above a certain point, we give them full anticoagulation. And then, so this is and steroids is also the universal one. I'm old enough to remember when the conversations about steroids in the 80s for sepsis and respiratory failure, and these are still the same conversations. The reality is that we actually do not know what works and on whom, but we're trying them on just about everyone. That's the reality. And it will be sometime before the dust settles. Now, there are unique things in intensive care that are different. There were conversations at some point, if there are not enough ventilators, and actually some of these came as directive from the state of Michigan, If there are not enough ventilators for the number of patients, who is going to receive this ventilator? And then the conversation became, do we know what the patient wants? Do we know who has a higher likelihood of surviving? And we didn't have to make these decisions, but these could be, and I know that our colleagues in Italy and Spain had to make these decisions, and they're very hard, gut-wrenching. And then you have patients who are on mechanical ventilation, have been on it for 2 and 3 weeks, and they're hovering. And at what point do you decide, okay, we need to move on to a different setting? What else do you need to do? I can tell you there are patients who are getting off the ventilator. We have 35 patients as of today on the adult central campus at DMC that are off the ventilator, which we consider that a good number. We have about 70 who are currently on the ventilator. So we're making progress, but it's all small and incremental, and it will take probably months before we know, try to identify what works for whom. And hopefully that will be the subject of results of clinical trials.
Great, thank you so much, all three, for the level of detail and all the explanations. I just want to point out that the audience is predominantly undergrad, and not all of them are incredibly, I don't know if medically literate is the right term, but if some of the responses could be rephrased moving forward. So for the last pre-selected patient-specific question, so to Dr. Msallam, we hear the term PUI, people under investigation, quite a bit. Could you please explain to the audience what it means and what it implies?
Yeah, sure. First of all, apologies to the audience for if we got into a little bit of the medical jargon. Please correct us and let us know that we're not speaking the usual English, if you will. So thank you for that correction and apologies from my behalf on my end. The PUI was a term that came under, so a PUI stands for a person under investigation. And basically this was a term that is really sort of now as we have more testing and the ability to get testing, it's sort of becoming, or it's falling a little bit by the wayside, and that depending on how fast you get. And so before, as everybody knows, we had a significant lack of ability to test people in a timely manner, and we still do, actually. We cannot test everybody we want to test. I can tell you that it took a while for everybody to develop their in-house tests for FDA approval to come through for private labs and hospital labs to get their own tests. And so when we first started, right, when we first started having some of these cases or these persons under investigation in the essentially around the 10th, 11th, 8th, 10th, 11th of March, we would actually get a test. We would test for influenza and other viruses and send this test to the state lab. That was the only place that it could get done. And even then, the state lab would send some of these to the CDC for confirmation. And so people essentially were under investigation for a week because their test results were pending. And frankly, we did not have the experience and the expertise that we have now, right? So we've been seeing patients now for a month. And I can tell you, we're pretty good at identifying somebody who we think has coronavirus, a COVID-19 infection. We've gotten really good at it. Essentially, that's all that shows up right now. And so until I can actually get a positive test, right, or potentially a negative test, that person is considered a person under investigation. There's a lot about testing that is still not clear. There's a lot about testing as far as the false negative rate, meaning somebody actually has the disease, but the test comes back negative, right? And the why that is. And then, are there false positives, and what does that mean? And so there's that whole scenario. I can tell you for us now, so we get pretty smart at picking up these diseases, and we develop expertise fairly quickly when that's all you're seeing. And so I don't need the positive test to tell me that somebody has a really high likelihood of COVID-19 for me to start to initiate treatment. And I'm pretty sure it's the same for my colleagues across the board.
Thank you, Dr. Msallam, for clarifying that. So a question in terms of a family-specific question. So of course, the family of someone who's contracted COVID-19 is going to be impacted. And from what I understand, Dr. Batah, you were a stable patient who then recovered. What should be expected in a situation like this in terms of day-to-day life within your household? And then also for critical patients coming to the ER or passing away in the ICU, we'd like to hear from Dr. Musallam and then Dr. Badr about your experience dealing with the patient's family. So Dr. Batah, if you could speak on your experiences, please.
Sure. Actually, this question is a very important question. And I just want to stress about what Dr. Badr said initially, that going for a month treating of these patients, we learned a lot and we changed protocols a lot and we learned from each other. So every day at Beaumont, for example, we have a meeting at 9:30 and all the physicians will tell us, their experience, and we have changed a lot of things that we were doing to improve the care for these patients. So the question regarding the question you're asking right now is, first, when is the patient stable to go home to his family first? And that was a challenging question. So initially we were keeping these patients not knowing when is it safe for them to go home. Is it when they're off oxygen? Is it when their oxygen, just a low dose oxygen, we can send them with oxygen? Is it when they have a fever or they're fever free? So these were all challenges that we had to deal with. So when the patient was either didn't go to the emergency room or went to the emergency room and sent home, or even if the patient got admitted to our floor and sent home, then what are you going to do with the family? So we're trying to quarantine these patients, and the CDC, by CDC recommendation, the time, the perfect, the number, the magic number was 7 days from the first day of sickness or testing, and 3 days free of fever and improving respiratory symptoms. But there are a lot of observations that these patients are still positive. And to give an example, I retested myself 12 days later, I'm still positive. So the question is that a true positive? Am I still spreading the virus or not? Nobody could give you the answer. There are some cases where the virus continues to be positive 3 to 4 weeks later. And that where the antibodies test come in place. And now we start doing those. There are a few places that are doing them in some hospital. But the question is, again, when are you safe enough to be with your family or to go back to your work? So in addition to that, the issue is a lot of families got affected, 1 or 2 members in family at the same time. For example, my wife got infected. One of my daughters had similar symptoms, but we're not sure. The other one didn't have any. So what do? We cannot test everybody. And how do you deal with that? So these are all challenges that we had to deal with. You got older patients who live with their families, and somebody has to care for these patients. And they're sick and their families are afraid to go there to take care of their grandma or grandfather. So these were all challenges that up till now we're still dealing with, especially not knowing when the patient is immune and when the patient is still spreading the virus or not.
Yeah, I think that what you're hearing is we have a lot of questions left that need answers, and we don't have all those answers. And so, the experience in China was that they kept people in the hospital for 12 days. And we can only surmise as to part of that was to control disease spread, was to ensure that patients are negative, that they were testing for negative results, and to try to limit, again, the public spread of this. Our experience for patients, there's outliers, obviously, and Dr. Badr's experience will be different in that in ICU, some of these people stay a long time. But our average length of stay at Henry Ford Hospital, I can tell you, was around essentially about 6 days, right? 5 to 6 days. Some people we sent home in 3 days because their oxygen requirement was no longer needed, right? And they were able to improve their respiratory status. They didn't need oxygen, or we were able to set them home with home oxygen. But then that's exactly right. You're sending them home to an environment where they could potentially and likely were still infectious. Can you hear me?
Yeah, we can hear you, Dr. Musallam.
Okay.
On our end, we see an additional connecting to audio.
Yeah, that's why I saw that. That was strange. I'll continue to speak. Anyway, so basically, we tell them to quarantine, we give them a mask, we tell them to stay in their rooms, kind of what everybody's seeing with perhaps Chris Cuomo from CNN and what he's doing is sort of self-isolating and quarantining as much as possible. But it's really hard, right? There's our patient populations may not have the ability to have a basement or a separate room or a separate bathroom. And so you tell them to wash their hands, right, religiously. You tell them to wear their masks. You tell them to, cough into their sleeve, to have their own, meals separately, that their dishes are washed separately, their clothing is washed separately to try to limit the spread. But frankly, that's a tough one. It's a really tough ask of a lot of our patients and their families.
So maybe I'll talk about some of the specific ICU issues, the human side of this is very challenging and very difficult. All hospitals now limit patient visits. So these patients are in the intensive care units without loved ones. They cannot come and see them. It forced us all to use technology. The hospital chaplain or the team sometimes will FaceTime with relatives and the immediate family. The big challenge of this happened when we get to the point of futility of care, when a patient is actually dying and they're dying alone. And that makes these conversations a long time. Usually these conversations about what would your loved one, what would your mom or dad or want for a situation like this, what are their wishes? These conversations usually we have them in a family room area in the hospital next to the intensive care. And it's multiple conversations, face to face, getting to know the families, showing genuine empathy. That actually simply can't happen because they can't come and visit. One thing that I've heard, our hospital is allowing one visitor under these circumstances when it's an end-of-life care conversation, obviously with appropriate protective gear. The saddest part is that very few people are availing themselves of this option, and I don't blame them because of the risk of exposure. So this part is very difficult. The people who are bearing the brunt of this are the nursing staff. They are on the forefront. Any one of us physicians, our exposure is reasonably limited compared to the exposure of our nursing colleagues. And this is one area where we have to truly acknowledge their role and their heroism in actually managing these very difficult patients. And that's obviously on the floor and especially in the intensive care unit. So these are challenging, but we're all learning and we're all learning from each other.
Omar, if I may expand, so I think what we may not be clear is that so pretty much all hospitals are not allowing visitors, even in the emergency department. If somebody brings a loved one in for care, for evaluation, they're not allowed to come in, which is brand new, right? This is not something that was done pre-COVID or before COVID. And as you can imagine, there's fear on both sides, right? The family member who attends that patient and is being asked to wait in their car. And then obviously the patients who may have their own set of anxieties, who do have their own set of anxieties and fears, and they're being cared for. And especially the ones who are really sick. And so you can imagine having these phone calls, these conversations. We tell people to call in, to talk to their loved ones via FaceTime. We're FaceTiming a lot of these other folks as well. So it's actually a big concern, and it's a huge thing that we've tried to figure out how to do it, but there's nothing like having family members at the bedside or visiting with their loved ones during something this scary.
Thank you for clarifying that and for each of your perspectives. Do you see that happening, or is that not something that's can be told with any certainty in terms of visitation? Dr. Musallam?
No, I think that as Dr. Badr said, that we are allowing, under extreme circumstances where somebody is, they are dying, we do want them to have a family member or loved one. And I think we're starting to learn about how to best protect ourselves. So, as the entire panel said, that we've all been working in the hospitals and we've been taking care of these people, face to face. We're actually doing procedures and we're literally right there from that perspective. And we figured out how to, protect ourselves, wear protective equipment, personal protective equipment, masks, face masks and shields and gowns. And I think that as we get better control of this and get better understanding of this, we will be able to, because we want families, right? That's key. We've gotten to a point in this country where we want the families, even around a significant grave situation where somebody is actively dying, and we want that family in there. It's closure for the family. There's, help from the patient's perspective. So I think we'll get there. We just need to learn a lot more about this disease, how it's spread, how to control it from spreading to those family members. The last thing we want to do is get somebody else infected.
Thank you for clarifying, Dr. Musallam. And so in terms of outlook, there's a few questions as we move forward. So to Dr. Badr, in your professional experience, what is the consensus on what works for treating COVID-19 patients?
The only consensus right now is that there is no consensus. Everything we're trying is based on observations, based on limited studies, and based on what we call expert opinion. And we are all sharing from each other. I mean, we are sharing protocols. We saw protocols at Henry Ford, at Beaumont, at Yale, at Cedars-Sinai, and people are sharing them freely. I think out of this, there will be a few candidate options that will be tested in large clinical trials. For example, one of these medications that will be used to treat viral disease is now being a clinical trial across the country, and they're doing in multiple sites. I think that probably is going to be the way to go. And until that happens, we may be able to get some results on which patient responds to what, but the problem is that these findings are contaminated by the fact that we're treating just about everybody with some of these. For example, the anti-malarial drug that we're using, well, everybody is getting it. So we cannot tell you who would respond and who's not gonna respond. We're not gonna tell you, we cannot tell you if it's effective because there is a percentage of patients who will get better on their own or untreated. So some of these may not be answerable, and some of it could be one of these, they call them these large databases that can be analyzed and you can determine some patterns. I think the hope is probably with a vaccine, because at least that could stem the disease, which allow it to become smaller, and then you can actually start doing some clinical trials. Right now, we're in a bit of a guessing game.
Thank you, Dr. Badr. Just to be mindful of the time, I'm going to skip some of the pre-selected questions. And for all the audience members who have submitted your Q&A questions, we're going to try our best to answer those post-webinar. We are going to have those after the webinar. So we're going to go through a few more questions and then one final question to wrap everything up. So Dr. Batah, if you could please speak on this question. What is the impact on the healthcare delivery system now? And what direction do you see healthcare delivery systems going because of this pandemic?
Well, obviously the healthcare is stressed and stretched to the limit with the number of COVID patients that we're seeing. The problem is twofold actually. Is first take care of these COVID patients, but the other problem is ignoring or delaying the treatment for the rest of the healthcare that is needed for the rest of the patients. Amazingly, in the hospitals now, I'm sure the other hospitals, same as Beaumont, there are a lot of patients that we used to see on a regular basis that we don't see anymore. We don't see a lot of, UTIs or people coming in after falls or even cardiac patients, congestive heart failure patients. We're not seeing a lot of these patients. That doesn't mean these patients do not exist at this moment. What that means that the patients are trying their best to stay away from the hospital. So that means they're not getting the care that they need. And a lot of times they get to the hospital when it's too late, or they're pushing, their symptoms off till it's safer, and then they'll come to the hospital when it's much worse than what it is right now. So the healthcare system in general is being really penalized and punished. But I think every hospital is doing the best they can to take care of what they have right now. Luckily now the number of the new cases is going down. So there are a lot of floors that are opening up, and they're taking away, some COVID patients and have them in different floors to open up some elective procedures. At Beaumont, for example, next week, they're going to open some ORs to do some elective procedures. The cardiac cath lab will be opening up also some procedures. So gradually, I think the next few weeks, we're going to see, some of the healthcare problems being solved or eased up a little bit, because we're going to start taking care of the rest of the patients that are not cared for right now.
Thank you, Dr. Batah. To Dr. Musallam, you're someone who works on both the international scene and also here in the front line. What do you believe the ramifications are for health behaviors in general? What are the lessons learned from this?
Yes, so, I think there's some similarities to what Dr. Batah was trying to address, in that the healthcare of the future is going to look different in many respects. So just to speak to that a little bit, I think that what we have seen is just a 7, 10, 12, 20-fold increase in virtual visits, telemedicine, and then obviously I think government and payers, right? So the healthcare, there's a huge business in healthcare, and so insurance companies paying for virtual visits and that sort of stuff, that's been opened up, and the government is paying for that, and so that's a big deal. So I think that we're going to see a big change in people wanting to do virtual visits, having visits with Dr. Batah, as opposed to coming to see him personally, having a video visit that is more convenient for them and for him, frankly. So I think we'll see a great deal of that. I think what you're seeing, what has kind of been impressive this past month, is that hospitals, as the trend goes, and internationally this is good, will be happening soon, and that hospitals aren't just for people who, if you feel sick, you don't just go to the hospital. You have to be really sick. You have to meet criteria to come into the hospital, because the hospital may potentially be a dangerous place as well, right? And we don't want to get people infected. We don't want them. We want them up and around. And we believe being at home is actually in the best interest of that patient. Again, if there's family and others that can take care of them. And so what we saw this past month was that the hospitals became ICUs, right? They were for the sick of the sick, the sickest of the sick, and people who weren't that sick stayed at home. And I think this is a great opportunity for this country and others to follow suit and continue with that, is that how do we keep people out of hospitals? How do we treat them best in the outpatient setting? Internationally, I think for the entire group is that this is a pandemic, right? I think what we've seen is that this disease has affected, the rich and the poor, has infected the athletes and the models and the superstar. And so it is basically has not, so nobody's been immune from it. We've all been affected by it one way or the other. And so everybody's been infected. And so I can tell you, I work in the Middle East, I work in India, and there was a high ranking royal in Riyadh that was actually in the ICU and was very sick. And that was a wake up call for that entire community to say, this is not a disease of the poor. This is not a disease of just urban cities. People get infected. And so that has been realized on the international scale. I think what you're seeing is that, unfortunately, there's lots of politics, and the fact that, sharing of information is so important in this time, right? The World Health Organization plays a huge role, and yet there's been lots of politics with that. And so we could have learned much better. We could have paid attention to a greater degree. And this is across all of it. Europe, right? You can see different countries reacted differently across all of Europe. Some have, done really great, and others have not done so well. And so the question is why? The healthcare systems across the board are not the same. Healthcare is not a right over the majority of the world. And then access to healthcare is a big deal. And so what's interesting is, for somebody who's in India a lot, I watch that country fairly closely, and what they've done is they shut it down. The Middle East have shut it down. Basically, it is a 24-hour shutdown, 24-hour curfew. You're not allowed out, as opposed to where we have much more liberties, that kind of a rule probably wouldn't go, where, you can't go, right? So And that's the only way they're trying to control it, because of access to healthcare, because of the existence of physicians and specialists such as the panel here, and then availability of equipment and well-equipped hospitals. And you can, so it could be potentially very scary and see that those numbers go significantly up. But I think it's an opportunity internationally for us to learn from one another and to continue to improve healthcare across the globe, because you saw it, right? It happened in China. We're not immune from it. You've seen it pretty much in I think it's in over 160 countries now. There is nobody that is immune. And we're such a small world, we're such a global society that, that those things can't stay at home anymore.
Thank you, Dr. Musallam, for your insight and perspective. Dr. Badr, I'm unsure if the webinar will cut out as we approach the end, but please, if you could offer your perspective on the following question. Actually, the question goes to all of you. Sorry, I was just checking. I'm being told by a timekeeper how much time we have right now, so sorry about that interruption. But if each of you could address the following question, the question I'm sure is on everyone's mind in the audience. When are we returning to some form of normalcy? Will we ever return to pre-COVID conditions? What's the future looking like, especially for students, the majority of our audience? I'll let each one of you give your input briefly.
Whom do you want to start?
Dr. Badr, if you could please start us off.
All right. The word normal may have to be redefined. I don't know when, if we kind of rewind the clock to go back to January of 2020, I don't know when this will take because the timeline in different parts of the world and in different parts of the US is different. While we may have reached the peak, but it is not the same in North Dakota or in Nebraska. And as long as we are one economy and one country and people are moving, we have to see that curve flattening or declining across. I think the return will be gradual, and it will have to be guided by science and by data. Another peak was what happened with the Spanish flu in 1918. So it is possible. So we have to be on guard. We just have to be vigilant. I think it's going to take a long time before we will feel completely safe that this is not going to come back.
Thank you, Dr. Badr. Dr. Musallam?
Yeah, I think Dr. Badr is absolutely right. The normal is, I think we should look forward to a new normal. It's going to take a while for us to get a vaccine and get everybody vaccinated. That's the only way we're going to be able to control this disease. And then it'll feel like the flu or something else, right? We don't know about if you are infected once, are you immune forever or not? Those answers have yet to come. And so I think one of the key things that we're seeing is as people get comfortable is that we have a flattening of that curve, which means that, we didn't peak and that not so many people got infected at the same time. What that doesn't mean is that it's okay to go out and that, as cases come down, we feel like it's safe. So as the example that Dr. Badr was speaking about, or speaking to the Spanish flu of 1918, is that people actually, when the all clear was presumed, they all went out. And then we had a second huge surge, which unfortunately killed more people than the first one. And so that is a concern. I think what we all, not we as the panelists, but everybody on the call, needs to continue to do their part, which is to continue to practice social distance and washing their hands, because this disease is by no means under good control. As you've heard, we don't have great treatments, or we don't know what works, doesn't work. And until we have a vaccine or have herd immunity across the board, this will continue. We are expecting to continue to take care of COVID-19 patients for the foreseeable future. And that probably runs through the winter and next year until we have a vaccine that's out there that we can actually get then everybody vaccinated.
Thank you, Dr. Musallam. Dr. Badr?
Sure, I agree with, of course, both doctors about what they said. The thing is, the vaccine is the key, and there are some news that a vaccine might be available in the fall, but who knows? The other issue that I want to stress on is availability of testing. So hopefully if we have more tests where we can test almost everybody who needs to be tested or everybody regardless, and also check the antibodies test on these people. So we'll be able to have some information on the immunity of the patients, how long they need to quarantine, so we can cut down on spreading of the virus. Going back to normalcy going to be gradual for sure, and it's not going to happen anytime soon, but hopefully things will improve along the way. But again, hopefully people will continue to consider that this is not a joke and they have to continue to follow the rules. And we know about the protest of people, and people want to go back and do whatever they want to do, but we all have to use our brain and have to follow some rules. Otherwise, we're going to have another surge soon.
Thank you, Dr. Batah. And as our final question, as we near the end of our time, could each of you, if you have any last advice or comment for the audience, share that with us? Dr. Badr, if you want to start us off.
Well, this may be, we've been warned about the possibility of a pandemic. Maybe the lesson here is that we as a nation need to be prepared to handle future pandemics. This is one, but another one could happen, and it could be in a different area. I guess preparedness for everyone is probably going to be the key.
Thank you,
Yeah,
Dr.
I think for me, complacency. It's really easy to become complacent. This is hard. Isolating in place, social distancing is very hard, very difficult. It doesn't feel right, doesn't feel natural. So it's easy to become complacent. Or worse yet, it's easy to get comfortable and think that we have it under control once you start seeing numbers are down. And so I would highly advise all of our listeners to continue to practice what is appropriate hand washing, right, wearing a mask, protecting each other and their families and loved ones from this. And then moving forward, I think that as you've mentioned, right, the majority of the folks on the line are students. And so there are future pandemics will continue to happen. If you read your history, right, this has happened every 100 years. And there's nothing to suggest that this won't happen again. So preparation moving forward is key for the long term.
Thank you, Dr. Musallam.
Yeah, what I would add just to that this is unusual and it's an experience. So everybody will say in the future that, you know what, I was there when the pandemic, COVID-19 pandemic was here. So this is definitely, we're all learning. Since the audience is mostly students, you're going to go back to your school soon. So you got to be careful, because at schools, things are different. We understand the restaurants and the bars and the parties and stuff like that. And a lot of times it's undercovered or not announced. So just be careful, because you don't want to be sick. Even young people could get really sick. So try to just, what's going on. Just follow the rules.
Thank you, Dr. Batah. And as we wrap up, on the behalf of NAAMA NextGen and the UNICEF Unite Detroit team, thank you all for taking time out of your busy lives to educate us. And you truly inspire all of us with your service. It means a lot to all of us in the audience here that you could take times out of your busy lives to be here with us. To the audience members, if anyone is interested in the work that UNICEF does in terms of assisting those afflicted with COVID-19 across the world, we're going to send a follow-up email, and in the chat put some links. We're also going to send some follow-up on what NAAMA NextGen does in general and in terms of what they do regarding COVID-19. So thank you everyone for joining us today. And the last thing, we'll try our best to answer all the Q&A questions after the webinar as well.
Thank you. Honor and privilege.
Thank you and good luck.
Thank you, Dr. Badr. Thank you, Dr. Musallam and Dr. Batah. So it's been a privilege.
Thank you.